Hello and welcome to Unleashed, the show that explores how to thrive as an independent professional. I'm your host, Will Bachman, and I'm here today with Mark Newsom, who is the founder and lead partner at Health Evaluations. Mark, welcome to the show.
Good morning, Will. Thanks for having me.
So, Mark, your entire career, you have been in and around and helping clients navigate the Centers for Medicare and Medicaid Services, right? CMS. Tell me a little bit about the overview of your practice.
We specialize in working with organizations that are focused on government programs in healthcare. So, Medicare and Medicaid, all overseen by CMS. CMS annually spends in claims, plan payments, and administrative spend over $1 trillion a year. So it's where the money is. If you're playing in the healthcare space, so it's not just about regulation and compliance and laws. It's also about revenue growth and bottom line. So we help out different players in the health space with business strategy as it relates to CMS, as well as traditional policy and advocacy type of issues. You want to get a reg changed or an interpretation of a reg changed. How do you go about that?
Fantastic. Tell me a little bit about your career before starting your own firm. I'd love to hear about your progression. I know you've worked in and outside of CMS, and just give us a little background on that.
I've spent 20 years in the health space in one way or another, either working in government or with private sector organizations. The one intersection for all of that is it all has to do with CMS, in that all the private organizations I worked for were either contractors for CMS, vendors, or they were regulated entities that were also being paid by CMS in the Medicare, Medicaid, or now the exchange plans from the ACA. So the whole 20 years has been at the intersection of CMS. Started off my career as a data analyst, have moved up into the executive ranks in some of the larger publicly traded health plans, and also have been a senior manager at CMS.
What did you do at CMS?
So I had two stints at CMS. The first one, I got brought on board when the Medicare Modernization Act passed in the Bush administration. And I got brought into the regulation team to implement the Medicare Advantage and Medicare prescription drug programs. And I focused on payment policy and bidding policy in those two programs, and then later worked on the IT systems in enrollment and payment. So my second tour duty at CMS, I ran a division called the Division of Payment Reconciliation, and the main responsibility of that team was to ensure the accuracy of Medicare Advantage and Part D plan payments. And then the second responsibility was related to the Affordable Care Act. Had a provision that required prescription drug manufacturers to pay a discount in Part D called the Coverage Gap Discount Program. And my team was responsible for invoicing those drug manufacturers to recoup those funds.
To what degree do companies that want to, serve Medicare or Medicaid, to what degree do they have to customize it for each of the different states? Do each different state kind of implement Medicare and Medicaid in a different way, so you have to have 50 different sets of rules if you're a provider?
In Medicare, it's a federal program that, for the most part, has a preemption clause in the law, so that there's just one set of rules. There can be different rules with what's called dual eligibles, and those are beneficiaries that are eligible for Medicare and Medicaid at the same time. Medicaid, however, fits the scenario you're talking about, where there can be a lot of variations between the states and the District of Columbia, as well as the territories, in terms of how their Medicaid programs run, different rules, different eligibility criteria. So, yeah, if you're a player at scale in Medicaid, you've got to be prepared to do some different things in each state.
What's an example of something really specific that you might have to, tweak for one state or another?
Anything from what's on the preferred drug list to does a state run their program through Medicaid managed care or traditional fee-for-service platform, down to who's eligible and who isn't. In some states, younger cohorts, it's really only for what's called moms and kids, meaning impoverished males are not necessarily eligible for Medicaid, and so on and so forth. Basically, there's a set of criteria that each state has to meet, but then they can go to CMS and get what's called a waiver and get all those criteria changed in various ways. And they do that. There's literally hundreds of waivers that states have. And so that's where you get all this variation.
Fantastic. I'd like to walk through a few case examples of the work that you've done with your firm. And we can obviously sanitize the client, sanitize the details, but would love to dig into some of the details of how you go about it and the types of things you might be called on. Could you start with an example, maybe a policy example where a company is trying to understand either how to interpret a policy or maybe how a policy is going to be changed or how to affect a policy?
Sure. I'm working with some folks in the telehealth space right now. That's taken on a huge importance because of COVID-19. But traditionally, the Medicare program, and both the original fee-for-service Medicare program and the Medicare Advantage program, did not have telehealth fully integrated into the program. And there's been some waivers and some changes as a result of COVID that have provided some great opportunities in the space. But those potentially will go away as soon as the public health emergency is over.
And so when you say not fully integrated, so let's say that I'm a Medicare patient, like my dad, for example, and
Yep.
So presumably, like, it sounds like what that means in practice would be previously he could go into the doctor and see the doctor in person and Medicare would pay the doctor. But if my dad did like a Zoom or a video conference with the doctor and explained his symptoms and the doctor prescribed something over the, just electronically without seeing him in person, maybe they couldn't get reimbursement for that same interaction. Is that what you mean?
That's right at a high level. As with anything in the federal government, there's a lot of technicalities, but at a high level, reimbursement issues were a big problem for a lot of providers, and they were for plans as well. So if a Medicare Advantage plan wanted to integrate telehealth into what they were doing, previously there were limitations in what they were even allowed to do. And then on top of it, there was no pathway for them to get paid for it.
Okay. And how did that change with COVID-19? Were there some sort of emergency regulations put out, and what were they? What changed over the past few months?
So what has been happening since the president declared the national emergency and Secretary Azar declared the public health emergency is a series of waivers and emergency, what's called interim final rules with comment, have been put out there, establishing flexibilities, including more benefit coverage and payment pathways. The legal authority to do that is based on having an emergency, or in some cases from the CARES Act. And so there's a lot of interest in, once the public health emergency's gone, what can we do under existing authority or getting Congress to pass new laws to make some of these policies permanent, so that telehealth is a fully invested option for seniors and for providers and Medicare Advantage plans going forward.
Well, that makes total sense. I mean, it's probably less costly for the office. They don't have to have as many people in the office or space in the office, and it's probably easier for the, people going. They don't have to get on the transport and go on the train for an hour, park, etc. So tell me about your role in a project like that. Like what would you and your firm be doing?
So my role in that kind of project is advising the client on how can they best convince policymakers to make this change permanently. What are the arguments? What are the kinds of evidence and data that will move the needle for that kind of thing? What are some of the plan Bs too? So getting permanent legal and regulatory change generally takes a lot of time. It's not something that happens immediately. It could be a campaign that takes months or even years or more. For example, there was a payment policy implicating physicians in the Medicare program called SGR years ago, and it took the physician community over a decade to get that policy changed. That's the extreme on that end. So advising them who they need to talk to, what are the arguments that are most convincing, what do they need to look out for in terms of naysayers. Often the naysayers are in the oversight community. So you get auditors that will, hey, if we do more telehealth, there's going to be more fraud, waste, and abuse. So how do you respond to that? What are some of the guardrails that you can put forward that would make sure that there isn't fraud, waste, and abuse? So those are the typical examples in a classic policy advocacy type of advisement.
To what degree, when you're trying to figure out what messages will resonate, to what degree do you have the ability to go and talk to former colleagues at CMS to just say, kind of informally, like, hey, how are you thinking about this? Or, what would be meaningful currently inside the agency? Is that a source of data for you? Or I'm curious to hear like how you think about getting those insights.
Sure. I would say they come from one of three pathways. You just mentioned the most direct and obvious one, that I go back and talk to somebody that I have a relationship with. I do that all the time. The other two are because I've been in that chair myself, having worked on the Hill and also worked at CMS. Often it's an issue that I already worked on, and I know how it was approached when I was there, and can look at it through that lens. And then the third is I have a pretty wide network of folks that are in other consultancies or in organizations, private sector organizations that are regulated and paid by CMS, and they're doing the same work. And so we compare notes all the time, including trade groups. And through those three pathways, you can usually put together a pretty comprehensive picture of what's going on, and what are the other issues competing for time and space with the policymakers.
So this is very interesting to me because just as a kind of lay person, not in the world of policy, I almost had like two mental models of how people might be interacting with the government, and it sounds like you're a third. So I'll tell you my two that I have. One is this sort of image of lobbyists kind of schmoozing like a politician, where they're taking a congressperson to golf or out to dinner, and some subtle way promising campaign contributions, or they've given campaign and they get access, and then they're kind of schmoozing that person. And then my second mental model is this much more formal process of hearings for public comment, or a commission that's accepting public comment on some new policy. But it sounds like the way a lot of work may be getting done is these more informal networks, not with the like the head of the CMS or the congressperson, but mid-level, senior level, kind of civilian employees interacting with former colleagues or people they know in the industry, and just having calls and talking about, what are you thinking about this, or well, what does industry think about this? Just more having informal, more porous discussions. Just tell me a little bit more about that, which is kind of new to me and not how I imagined government is working.
So you nailed it. All three happen, and I've done all three. So let's talk about that third pathway. Healthcare is complicated. It's technically complex in terms of the actual provision of medical care and pharmaceuticals. And then inherently, healthcare is an IT business. You're trading claims, you're doing enrollments, you have electronic medical records, you have data from test and lab results. So it's a very data heavy, very IT focused industry, both on the private side and the government. And so in order to do healthcare well, irrespective of where you are, and the government's no different, you have to have access to a broad set of knowledge and technical expertise. And that's where this more informal, sometimes formalized too, the government will go out and contract with McKinsey, with Booz Allen Hamilton, with academic organizations of prominence like Johns Hopkins, to do technical reviews of things, to advise them on how to not just change policy, but how to implement it. One of my early mentors, I had just finished working on the regulations implementing the Medicare Modernization Act, and I was very proud of myself, and I just won the Distinguished Service Award from the Secretary of Health and Human Services, and he laughed and said, well, this isn't real until we implement it. And he was right, because you can have, at the end of the day, policies, laws and policies are just paper. Until you have operational processes and IT systems in place that actually work, it's not real. And so that's a huge part of all of this is and the part that doesn't get coverage on TV, right? You're not going to watch Meet the Press and they're going to talk about the enrollment system at CMS. And yet that's what's more likely to impact a senior day to day if something gets messed up in an IT system than any policy will.
Right. And I imagine that if you're at the government agency, if you're at CMS, I mean, it's all fine to hire McKinsey or Booz Allen, or to do a formal kind of hearing process where you're asking for formal inputs. But it's probably, I mean, you want your regulations to be practical, and so it's probably a helpful thing to be able to just call someone that you trust who's out there in the industry and say, hey, like, how the insurance company actually thinking about it if we do it this way or this way? Like, what's actually going to be more practical for you guys? And just having that more informal back and forth.
Absolutely. And all the above gets done. They got the formal processes, and you're submitting a comment letter, and it's on regulations.gov and all that kind of stuff. And then there's the informal stuff that they're doing with the stakeholders, but also with their own contractors.
Mm-hmm.
And so, CMS has a lot of IT contractors, for example. They will often talk to those guys and say, this is what we're thinking about doing. What's the state of the art here in terms of, is there, for example, a cloud-based solution to what we're trying to accomplish? And we're seeing a lot of that right now, where the traditional CMS architecture was an old-fashioned mainframe right at the headquarters using a Teradata database, and now they're moving everything to AWS cloud, and that gives them a lot more capability to do real-time analytics. And so they're now talking to tech firms, analytic firms, statisticians about, what can we do in terms of machine learning, AI? What can we do in terms of deep learning, predictive analytics, now that we have this better architecture and better technical capability from an engineering perspective?
So you've been around a bunch of different roles. What is your perspective on how much impact do political appointees have? So the Secretary of Health and Human Services and the head of CMS, like, how much impact do they have on this nitty gritty of regulation development?
So they have a lot of impact, more at the broader, higher level. In many ways, I would make the analogy to them being more like a board of directors in a corporation. The political appointees that have more experience and maybe did those other jobs earlier in their career, they will, on a one-off basis, get more involved. So Secretary Azar, for example, had worked in the Bush administration, or when Mark McClellan was CMS administrator, he had lots of previous experience, including being FDA commissioner. Those kind of individuals are able to leverage that experience, as well as sort of their own networks within the government, to get more involved. But that's, of choice and capability.
So I try to keep this a non-political show, despite my own
Yep.
firmly held convictions. But I'm
I hear you.
so I won't I try not to disclose those or get into that. But I'm curious to hear: do you see much kind of difference? Sort of at the certainly in the political arena, there's lots of distinctions and so forth, and that we all know about. But when it gets into something kind of more technical, like running Medicare or Medicaid, is there much really distinction between who's in office in terms of things like, enrollment and, reimbursement and IT and all these different regulations and so forth?
There is, but less than I think most people would think. I advise my clients, and always advised folks in the corporate world when I was there, inside, that be careful of headline noise. no criticism of Wall Street Journal or New York Times or any of the traditional media sources, but those media sources don't exist to give you actionable information to run your business. They're there as a media business to sell a story, and that story is probably not going to be at the level of detail that matters for your business. The more technical something is, the less partisan it is. So you brought up the example of, say, an enrollment system. An enrollment system's not going to get politicized. The higher level legislative and regulatory policy, do we have Medicare for all? Do we pay primary care physicians more and cardiologists less? Should we have a Medicare Advantage program? And if so, are we paying it too much? Those are the kind of like political questions where it really matters who gets elected. Obviously, had President Obama not gotten elected, we probably wouldn't have had an ACA, for example. And so I don't want to make it sound like politics doesn't matter. It does, but it tends to soak up a whole lot more oxygen than what is realistic in terms of the day-to-day of claims payment systems, just the general operations of running these mammoth healthcare programs.
So we talked a little bit about telehealth. What are some of the other decisions or like new regulations or changed regulations or any sort of changes that have come out over, let's say, the past year or two that are totally below the headline level, so you'd never read about it in the New York Times or Wall Street Journal, but are actually really important and people in the industry really care about? So what are some of these, like, below the radar developments that we haven't seen in the mainstream press, but people like yourself really care about?
There's a lot. These things tend to happen every day. So I think in the provider side, some of the subspecialties that are getting big cuts, like physical therapy in the physician fee schedule.
No kidding. Physical therapy. Huh?
And so, and that's not a negative comment on the value of physical therapy. It's widely recognized how important physical therapy is. The issue is the law says that the physician fee schedule is under what's called budget neutrality. And what that means is if there is a political / policy push to pay other providers more, you have to take it from somebody else. In this case, for many years, there's been a recognition that primary care physicians, in particular, should be reimbursed more. And what we're seeing is, in order to keep the overall system budget neutral, as primary care gets paid more, other specialty types are being cut.
Zero-sum game there.
Yep. And so that's happening. I think the interoperability regulation. The Office of the National Coordinator of Health IT and HHS and CMS co-released regulations promoting interoperability of medical records between all the different folks in the ecosystem. And that regulation was supposed to be going live already. There's been a bit of a delay in implementing it because of COVID. But there's also a recognition that interoperability is pretty key to providing the highest quality care, especially in a COVID situation where more things are being done on the phone or via video telehealth, and patients can't necessarily get to the office as easy. And then in every part of the healthcare ecosystem, there are payment rules. The hospital inpatient prospective payment system. I already mentioned the physician fee schedule. In Medicare Advantage and Part D, there's something called the annual rate notice process. And all of those documents are thousands of pages long in aggregate and have many, many technical, weedy details that impact the bottom line of the organizations in that space.
I'm imagining that there is this cohort out there of people who are, the VP of policy at United Healthcare, the kind of head of McKinsey's healthcare policy sub-practice, people who are on the Hill who are staffers focused on CMS, people who are currently at CMS and used to work in industry, and vice versa, people like yourself. And I'm curious, to what degree is that network of folks, like, do you all know each other, or is there some kind of annual conference that everybody goes to, or is there a private group or something, or how do you and the people in your sort of that sphere of people that are all like relatively senior, that kind of been doing CMS policy for 15, 20 years, how do you all kind of connect and know each other?
There is a fair amount of overlap, at least in the advocacy side of the world. The overlap tends to fall apart the more operationally you get. I'm a odd duck, if you want to look at it that way. I like to talk about this is how I'm differentiated. That not a lot of people have worked both in legislative regulatory policy and also operations. I've worked in acquisitions, due diligence, all that sort of stuff. Very few people have done all the above. But in terms of, is there some sort of Masonic secret society of all of us? No, there isn't. Are there organizations and conferences, particularly in a pre-COVID world, where sort of everybody gets together? Yes. I think, in the Medicare Advantage space, the annual Medicare or Medicaid conference that America's Health Insurance Plans, or AHIP, puts on. In the prescription drug space, the Pharmaceutical Care Management Association, or PCMA, that represents the PBMs, generally has a spring and a fall conference, one in Florida, the other in Arizona, where PBMs and almost every major prescription drug manufacturer are interacting. Also, exclusively focused on the MA space, the Better Medicare Alliance, which is an organization representing plans and providers in the MA space, has an annual conference focused on that. If you're talking about tech, HIMSS. If you're talking about,
I'm sorry, what's HIMSS?
HIMSS, the Health Information Management Society. They're predominantly electronic medical record vendors and other health IT players. That gets a lot of coverage. At more of the C-suite and deal levels, JP Morgan and events like that tend to bring everybody together. And then depending on your specialty, so these things also exist for lawyers, for example, or the Healthcare Lawyers Association that has annual meetings and brings everybody together. And I've spoken in a couple of those as well. So there are events that bring everybody together. There are some events that CMS does that bring everybody together. But it totally depends on like your specific function in many ways. Are you a lawyer and working for a GC? Are you a health IT guy, a data guy? Are you a lobbyist that may implicate which one of these types of events you go to? I tend to end up going to all of them.
All right. Outside of these events, how do you stay up with the news of this industry? So it's clearly not reading the New York Times. Are you just looking at every press release from CMS, or is there some really good like blog for the industry insiders or some newsletter? Like, how do you stay up to date on all the stuff that's happening?
So I think two things, mostly my own analysis of the regulatory minutia and data released by the agency, then supplemented by having conversations with people in my network, people at CMS, other people that do the kind of work I do, or are in-house in businesses. And then I like to try to keep up on particularly the publicly traded space. I'll listen or watch earnings calls from most of the major players to get the perspective of, where's business approaching these issues. And if you've ever listened to these calls or been on the inside and helping out investor relations in your company, you'll see that most of the street analysts, they're paying pretty close attention to this stuff. The other day, CMS, for example, released the premiums and star scores for Medicare Advantage Part D plans. And, in less than like 4 to 8 hours, you started seeing investor notes on, here's how plans performed in that respect. So in that space, people pay a lot of attention to policy developments because it impacts revenue growth and bottom line.
Yeah, speaking of that, I'd love to hear another example of one of your projects, maybe more focused on business growth. We talked about some of your work, kind of looking at policy and how to influence that. What would another project type for your firm be?
So a good example would be a provider organization trying to figure out their strategy based on where policy's going, realistically, not talking about, hey, we're going to get laws changed and regs changed. Sort of if we can't get anything changed, and then some prediction of if changes happen, what's the long term look like, and trying to figure out their overall long term strategy, where the risks and opportunities are. And that's the kind of work I also did inside on in the companies I work with or for on due diligence. So you're looking at an acquisition target. Are you pricing it right, factoring in that policy may be shifting on that target and they may be paid less or paid more going forward? And so that's becoming an important part of any due diligence activities on deals.
So some of those policy types you mentioned, for example, just the reimbursement schedule. What are some of the maybe more technical or like out of the way regulations that would actually be pretty meaningful that you're looking at or trying to forecast?
So often it's access to markets, or your ability to put together a product and service and for it to be compliant. So going back to the telehealth conversation we already had, traditionally, telehealth wasn't part of the benefit structure for Medicare. So if you were a Medicare Advantage plan years ago, even if you on your own as a business were willing to take on the risk of, hey, there's not a clear payment pathway for me, but I think I can do some innovative stuff integrating telehealth. Well, the rules said you really couldn't. And so those rules now have evolved even before COVID to allow more flexibilities for plans, but it took time to do that. And so there were business strategists that had some really good, innovative ideas years ago to use telehealth, and they couldn't because the rules wouldn't allow them. Then you've got another example in the Medicare Advantage space. There's a lot of growth in dual eligible special needs plans, and traditionally most of the rules for that were strictly from CMS, but over time CMS, in talking to states, decided that the states should have a seat at the table. And so now plans need to have contracts and agreements in place with the state that they want to have the dual eligible SNP in, and that can create barriers to market access, because if you look historically, states tend to only want to do business with players that they're already doing business with. So you essentially have to be fully engaged in that state's Medicaid program to now have a D-SNP book in Medicare Advantage. And there's literally hundreds, if not thousands, of examples like this of little tiny technical things that can make or break your innovation strategy.
So companies clearly really need to understand that in a lot of detail. What are some?
Yeah, I mean, this is why if you look at a lot of startups in the healthcare space, particularly in digital, will actually actively avoid government programs because they're afraid of it. They don't think that they can play this ball, and so they'll focus on self-pay, commercial. They'll focus on self-insured employer group plans that don't have the regulatory regime that Medicare, Medicaid, the exchanges, and other government programs have. The challenge with that, if you want to scale, is that's where the people and the money are. The higher utilizers of care are Medicare beneficiaries and Medicaid recipients. More and more Americans are in government programs. It's very difficult to scale a healthcare business and say, I'm not going to do business in a government space.
Amazing. So this is such a fascinating view into this world that it does kind of fly under the radar to some degree. And I didn't realize it was a $1 trillion in spend. I mean, that's like bigger than the Defense Department. That's amazing.
It is. If CMS were a country, it would have a gross domestic product larger than Belgium. It's a mammoth organization impacting a whole lot. I think the other thing that a lot of people don't realize too is we don't have single payer government-run healthcare, but because of the size of CMS, often a lot of what happens in the private commercial healthcare markets are really just a cut and paste of what CMS is doing in Medicare with some changes.
Give me an example of that.
So if you're an employer group commercial health plan and you're negotiating with a hospital to be in your hospital network, more often than not, the beginning of that contract negotiation process is the hospital payment system in Medicare, and then you start negotiating tweaks. I'm going to pay you more than Medicare, we'll tweak these few things, but the the whole thing's on a Medicare chassis. So you're starting with what CMS is doing. Pretty much all claims processing starts with a Medicare claims sort of data framework, and CPT and HCPCS codes, which are copyrighted from the American Medical Association, but it's really CMS's adoption of that in claims payment that then filters into the whole rest of the world. And so even if you're not in a government program specifically, chances are what you're doing in healthcare is replicating a lot of what Medicare does, just with some tweaks.
All right, great. So if people wanted to follow up and learn more about your firm, where can they find you online?
The best way to find me right now, because I'm working on some website development, is through my LinkedIn profile or emailing me.
Great. And I'll include your LinkedIn and your email in the show notes.
Awesome.
Mark, hey, thank you so much for joining today. This was a fascinating view into the world of Medicare and Medicaid.
Appreciate it. Have a good one.
All right.